HHS Town Hall for Thursday, November the 12th. I'm Aaron Levo. I'm the Vice President of Communications and Public Affairs here to moderate our Q&A and just basically get us started this morning. We're going to have a detailed conversation today with Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control. But before we do that, I'm going to ask our President and CEO, Rob McIsaac, to deliver some remarks about where we're at and what's on the agenda today. Rob, over to you.
Thanks very much, Aaron, and good morning, everyone. And as always, thanks for tuning in. You know, in thinking about our COVID-19 journey, it struck me that even if the pandemic were over today, it would have been a long, difficult, daunting journey. And so it's such a test of resilience for all of us now to be watching record case numbers being reported across the province and across the country. Given what's happening in the community, it's not surprising. We're seeing some additional COVID patients at HHS, although the numbers are still manageable. Much of the work we are doing as a leadership group is focused on preparedness planning and doing everything we can to try to keep our patients, our staff, physicians, and our community safe. As challenging as all of this is, I never stop being impressed and have never been more proud of the HHS team and how they simply get down to doing the work and getting the job done. So thank you all for all of the continued great work. Today, we're handing the mic over to Dr. Dominic Mertz, our Medical Director of Infection Prevention and Control, to walk us through the latest COVID evidence and trends and what it all means. It's such an amazing thing to have an expert of Dr. Mertz's caliber to call on for advice and reflection and to answer questions. Dominic and the team he works with have done such a great job of keeping HHS and in fact our whole region abreast of the latest developments on what has been a rapidly changing file. He has helped to keep us as safe as possible during this very challenging time. After his presentation today, you'll have a chance to ask questions of Dr. Mertz, so be sure to jot down some notes as we go so that you can ask him hard questions. So without further ado, I'll turn it over to Dr. Mertz.
Yeah, thanks, Rob. And first and foremost, I would like to say it's really a team effort, not only at HHS, but at the regional level, which helps us all making the right decisions along the way. So what I was tasked with for today is talk a little bit in more detail about the epidemiology worldwide, in Canada, Ontario, and then certainly a local lens as well. And not only looking at cases, I will also present some data on hospital admissions and deaths. I will also go into serology studies. There's lots of questions that we are being asked about those, what it means, and then the mortality rates, where you see different mortality rates being thrown around. And I would like to introduce two basic concepts on how you can measure mortality, CFR and IFR, so case fatality ratio and infection fatality ratio. And I will explain that in more detail what it means. And then in the light of the news from Pfizer this week, touch on vaccines as well. Next slide. So this is data. I put the slides together yesterday, so not perfectly up to date, but by yesterday we had worldwide 51 million cases of COVID-19 that had been confirmed, the true rate probably being factor 10 or around that higher. Most cases in the US, India, and Brazil, so all countries that have a large population as well. On the right-hand side here, you see the Epicurve, and just what I would like to highlight here As you can see, the number of cases continue to increase. It's not that we had a global wave 1 and then a global wave 2. Globally, we are still deep in wave 1. Next slide. Another way, and that's a more meaningful way to look at case numbers, is to look at what's currently happening and to take into consideration the population. And the most common metric that's being used, and I've also embraced in the Ontario framework, is cases per 100,000 per week. The US currently sits at 248. India and Brazil much lower, 24 and 47 respectively, but keep in mind that they probably also test less, so their iceberg may actually be much bigger than what we see here. France, one of the leading countries, so to say, in terms of rates, so it's 523, Russia around 100, the UK in a similar ballpark as the US. Next slide. And please keep those numbers in mind when we talk about the numbers in Canada. When looking at deaths, we are at 1.2 million confirmed COVID-related or associated deaths. Again, lead by the US, 240,000, Brazil and India, so the three same countries. What's interesting on the right-hand side, when you're looking at the Epicurve for death, it's pretty flat since March, April, which clearly suggests that we know much more about COVID. We identify many more cases. So despite the fact that the number of cases per day continue to increase, death remains relatively stable since March. Okay, next slide. I added here the case fatality ratios just to give you an idea. Globally, 2.5% of known cases have died. Highest here among those top 10 is Mexico with 9.9%. Most countries are sitting somewhere between 1.5% here for India, up to 5 and 5.5% for Italy and Iran. UK, interestingly, after the first wave, had one of the highest mortality ratios, probably because they missed the most cases. They were sitting at 15% and came significantly down now. But again, I will go into more details what may influence this large heterogeneity that you see in terms of mortality rates. Next slide. So that's a Canadian picture, Canada-wide to date, roughly 275,000 cases, the majority of cases, as you know, in Quebec and Ontario. Next slide. Again, the more meaningful metric here, cases per 100,000 per week or per 7 days. And you remember the global data I shared previously. Canada is sitting at 75. Ontario, we are at 55. So actually, other than the Atlantic bubble, currently the lowest rates. Highest in Manitoba with 183. Alberta at 113. And we are in the same ballpark as Saskatchewan and BC at this point of time. Quebec somewhere in the middle with around 100. Next slide. Another way to look at what's going on is really looking at the trend or the dynamic, and these are RT values. So an RT of 1 means that an average person infects on average one other person, which means that the number of cases stays stable over time. Whenever that's larger than 1, your number of cases will increase over time. For Ontario, that estimate, and there's many ways to calculate RT, and one RT is always different from another RT, but using this approach here, 1.19 means that you have roughly 20% increase in cases within 4 to 5 days, because on average, one person infects 1.2 others. And again, you can see that Manitoba, Saskatchewan, and BC are higher. They are above 1.2, while ourselves, Alberta and Quebec, are in that range between 1.1 and 1.2 at this point of time. Next slide. So when we are looking at the Ontario Epicurve, what you see is we had that first peak back in April with a max of 650 cases per day. This is cases by episode date. And now today we had 1,500 reported. That's reporting date. So this will be like distributed over the last few days, but certainly we see more cases than we've ever seen before. So roughly an increase at this point of time by a factor 1.7, and we are certainly not at peak yet. Next slide. When we are looking here at deaths, however, you can see that we are quite far away from what we've seen during the first wave. And again, we will come back to that. To some extent, it's certainly that despite the fact that we still continue, sadly enough, many long-term care facility outbreaks, it's not as bad so far as it had been during wave one, which probably is a major factor here. But also the fact that we just pick up many more cases than we would have had back in March and April. So the true number of cases back in March, April probably was still much higher than what we are currently seeing. Next. The same translates into your hospital admissions as well. So that's number of hospital admissions on average per week. We peaked at 1,100 hospitalized cases during peak one, and we are currently in the 400 range. So you see two things, right? You see that known delay from identifying cases until you see an increase in admissions and until you see death. That's what I shown before. But you also see here that most likely we don't see the exact same epidemiology, or not yet, as we've seen during wave one here. Next slide. And that's our picture currently in Hamilton. When you look at the Epicurve again, it's by episode date. That means that all those bars on the right-hand side may still change. And by changing, I mean they may actually get higher because cases will be added to that. We had our first wave with no clear peak in March and April. Then we had another peak, which was our Roslin outbreak. End of June, we entered stage 2. Number of cases actually decreased further, not because stage 2 was any better than lockdown, it's just because it was summertime. Then we had mandatory masks and stage 3 implemented. Please go back again. One back, yeah, thank you. And after that, in August, we saw a first increase, then mid-September, the next increase started. And important to note here, it wasn't an increase that started a couple of weeks after opening school, which would have suggested that school's actually the driver. We saw the increase already when schools started to reopen. And then we had the Spinco outbreak, which resulted in that first peak, then came down again, and now we see again an increase. Today, 30 cases have been reported. Next slide. When we are looking at unlinked cases, and that's really what's representing the risk in an average random healthcare worker or patient, what's their risk to actually have COVID without knowing? And this is on the right-hand side in the figure, the yellowish bar. Yellow means unlinked case. Blue, which is typically the majority, are those for whom we have a known contact. And purple are the outbreak related. And the outbreak related obviously undulate a lot because you have a major outbreak, you see much more purple, and then you don't have a lot of outbreaks, then you see less purple. When calculating the unlinked cases per 100,000 per week regionally for our public health units, as you can see here, Hamilton is at 11, Niagara in the meantime actually lower than the 12. So we are still quite lower than the 20 that we would have defined as our internal threshold to change to non-low epi policies. Next slide. When looking at number of deaths here, it certainly picked up now in November, mostly driven by, again, the long-term care facility outbreak that we unfortunately start to see again. At the bottom, what Rob already mentioned in terms of hospital admissions, we see an increase. The average this week, I think, is at 15 cases. We've been at the max of 70, but that was with the Roslin before that at 30. So certainly getting into the range that we have had prior to the Roslin wave one. Next slide. Okay, switching gears now to serology studies. And the question here is really, how much of the iceberg of COVID cases do we see with our PCR testing? Next slide. So this is the Ontario data. What is Ontario doing? They are basically using residual sera that were sent to the PHO laboratory for any reason, PHO Public Health Ontario lab, which raises one question. It's unclear how representative this is for the population at large, but it's the best we have. There's also limitations in terms of sensitivity and specificity, so whether a positive serology necessarily means that you have had the infection, and whether negative really rules out that you have had an infection. So there's certainly gray zone there, but as I said, it's the best that we can currently get. The adjusted rate of positivity over August was 1.1%, roughly 4 to 5 times higher than expected based on the NPS testing, which means that for each case that we identified, there were actually 4 others or up to 5 others out in the community that we wouldn't have known about. Next slide. And this is relatively stable across all age categories, as you can see here. It seems a little lower in the above 80, at least back in August, and a little bit higher maybe in the 40 to 60 years of age range, but no, I would say no very significant differences, and all very small numbers, obviously. Next slide. When we are comparing our region to other regions within Ontario, Toronto, as you would probably expect, has the highest seroprevalence with 1.7%. We are somewhere in the middle with our 1%, Eastern and Northern lower at 0.3 and 0.4 respectively. Next slide. But there's certainly regions in the world that have been hit much harder, as you know, and as you would expect, have much higher antibody levels. This is data from New York. You can see in the Bronx, 1 in 3, Manhattan, 1 in 5 of tested individuals had antibodies at that point of time. And there's that one neighborhood here, must be a coincidence, that actually has the name Corona, where 1 in 2 individuals have had antibodies against the coronavirus, suggesting that in those hardest hit neighborhoods, it makes it less likely that they will see another very significant outbreak, but there's still 50% not infected yet, and that's something one has to keep in mind. Next slide. So where does serology help us? It's A, to get an idea of how much we miss, and second, to get a better grasp on what's the actual mortality rate. So I already introduced the concept of the CFR, the case fatality ratio or rate, which is the number of deaths from the disease divided by the number of confirmed cases, or PCR confirmed cases in our situations. Times 100 gives you a percentage there. The IFR, or infection fatality ratio, is again your number of deaths from the disease, but now divided by the estimated number of infected individuals, and that's where you use serology data instead. So obviously your IFR is much lower, or at least lower than the CFR. Next slide. Our case fatality ratio, CFR, in Canada sits at somewhere between 4 and 5%, similar to the UK, to Sweden, and that's Zimbabwe down there. But you can also see on this map that there's in particular African countries that have a case fatality ratio of less than 1%, while there are other countries like Mexico that I mentioned, which is in the range of 10%. So a very large range of what you see in terms of case fatality rate. Next slide. So why is that? It's the same virus after all, and you would sort of expect that your mortality rates are similar as well. And I listed here several most likely explanations for that. So first, it's transparency or reliability of reporting COVID deaths and COVID cases as well. That's something we sort of assume, but there's certainly question marks with some countries around that. Then it's about the population affected. So if you have a low-risk population with that's on average much younger, as you would see in most of the sub-Saharan countries, you would expect a lower case fatality ratio than in a country like Canada, where we had, unfortunately still have, major issue in our long-term care sector, where the vast majority of deaths actually occur. I think we are still in the range of 70 to 75% of all deaths occurring in long-term care facility residents. Then the surge of the healthcare system is another important aspect. So if you have a Wuhan scenario or Northern Italy scenario during wave 1 or New York in wave 1, you are unable to provide best possible care, and as such you have added mortality because there's death that you could have otherwise prevented if you had the capacity to deal with the patients the best possible way. So this affects both case fatality ratio and infection fatality ratio. What's case fatality ratio specific is first and foremost your criteria or capacity for testing, because the more you test, the more mild cases you find, the lower your case fatality ratio gets, and the closer to the infection fatality rate you are. Next slide. And I use my home country to share some data because I think Geneva is the only jurisdiction that has a population representative sample of people that are serially tested for antibodies. So next slide. And this is data from basically the first wave published in July in Lancet Infectious Diseases. And this table shows you what you need to know. You need to know what's my population best categorized by age, because as you will see, your infection fatality ratios are massively different when you compare the young with the very old. Then you need to have a good estimate of your seroconverted population. And again, it's an estimate. You have a sample of people that you actually test for antibodies, and then you generalize that to your entire population. And then you need to know number of deaths in each of these age brackets. And then next slide, you can calculate your infection fatality ratio. And I just added here in red boxes the numbers so it's easier to read. So in the less than 20-year-old, there's roughly 2 in 100,000 deaths estimated. This being said, they didn't have any in Geneva here, but statistically you end up in that ballpark because there's uncertainty there because you're estimating, right? Then in the 20 to 65-year-old category, it's roughly 1 in 10,000. And then increasing significantly in the older than 65-year-old category, where you are more in the percent range here, 5%. And on the next slide, you can see a Nature publication that was just published last week that looked at the same age-specific infection fatality ratio estimates, and they tend to be slightly lower than what I've shown you in Geneva, but very similar picture, and you see pretty much a linear relationship between age and infection fatality ratio. They only got up to 1.5% in the older than 80 population, which was surprisingly low, and certainly lower than the Geneva data, but overall very consistent across most studies that looked into infection fatality ratios. Next slide. So some good news after having talked about deaths or the vaccines. And as you know, Canada has contracts with several manufacturers, all listed here. I think we are at 5 currently, and they use different approaches to the vaccine. The messenger RNA vaccines being a new technology where you inject messenger RNA and then your body sort of produces the viral proteins, and then your immune system can develop an immune response against those proteins, which are shared with the coronavirus, obviously. That's the Moderna and the Pfizer vaccine. And then the more traditional ones where you inject pieces of the virus adjacent to another molecule or another virus to again introduce an immune response to SARS-CoV-2. And then there's also China, Russia, and the United Arab Emirates that actually already using vaccines at a larger scale. So they sort of approved it for certain population, despite the fact that they don't have the clinical studies completed yet. Next slide. Now, the big news this week was certainly Pfizer coming out with some interim results, unfortunately through the lay media rather than sharing some scientific data, but that's the time that we see within COVID repeatedly, that people put out their findings first through the lay media before you can actually see scientific reports. So let's look at it with a grain of salt, but certainly very promising data with 90% efficacy for the vaccine in preventing clinical infections. Russia, a couple of days later, said we are even better. We have 92%. No data being shared. There were also questions about their data that they shared on phase 1, phase 2. So take an additional grain of salt for the Russian information. It looks like Moderna will come out with some data later this week, and rumors are they are in the same ballpark as Pfizer. So that's certainly good news that we may have a highly effective vaccine eventually. Next slide. This is just a summary that's from the New York Times. We have 11 vaccines currently in large-scale efficacy tests, and these are the ones that are required for approval. We have those in limited use, again, in those countries that I mentioned. But even if those 11 wouldn't work out, or some of them wouldn't, we still have dozens of vaccine candidates in preclinical studies that may eventually help us moving forward. Next slide. So what do we know and what we don't know about the vaccine? So first, what we know that SARS-CoV, like any virus, does mutate to some extent. It doesn't mutate to the same extent as we would see with influenza, at least so far, which suggests that once we have a vaccine, we don't have to reinvent the vaccine every year and adjust it. It will probably stick for at least a while. What we need from the vaccine, as I already mentioned, is what it tries mean then efficacy, eventually its effectiveness in the real world in building immunity. Optimally, we would need a vaccine that prevents transmission. So you cannot get infected and you cannot transmit it any further, which would allow us to eventually have herd immunity and potentially eradicate the virus. So that would be the best case scenario. At the minimum, we want to prevent disease. And the way the study results are reported from Pfizer, it's probably most likely a B. It prevents your clinical infection. So you don't get sick from the virus anymore, but you may still be able to transmit. At the very minimum, you want to prevent severe disease. That's more like what the pneumococcal vaccine does, which would be good enough to have, in particular, our long-term care facilities safer, so at least to prevent severe morbidity and mortality. With B and C, we will never achieve herd immunity. We will not be able to eradicate the virus, but we will be able to prevent significant harm from the virus. So it would become one of our respiratory viruses that we are dealing with on an ongoing basis. And with the vaccine, we can reduce the impact there. Can we go back to the other slide again? Thanks. Good news is several vaccine candidates showed a very strong immune response in phase 1-2 studies. And this needs to be confirmed now in the clinical studies phase 3. And we also need to learn about the safety, in particular with a new technology like messenger RNA vaccinations. We want to make sure that it's safe before we use it at the large scale. Next slide. So what we don't know is duration of immunity. You're aware that there's reports of reinfections. It seems to be a very rare event. I think we had a couple of dozens cases at this point of time among millions of infections. So it seems to be very rare, but it does occur, and that's relatively normal. But we need to learn whether it's for 1 year, 2 years, or just a few months, and we don't know yet. then the logistics of vaccinating optimally almost 8 billion people will be a major undertaking and will take years. Then the cold chain issue, Pfizer vaccine requires minus 80 degrees Celsius. It's certainly possible, it's even possible in sub-Saharan countries, but it adds a layer of complexity for sure. And then we need to decide who to vaccinate first. Is it high-risk professions such as healthcare workers? Is it first those that are elderly, have multiple comorbidities, and are such at highest risk for severe infections? Or because it doesn't work as well in that population as we would probably see, for example, see with the influenza vaccine, maybe it's even more important to vaccinate those surrounding those people, so sort of indirectly protecting those. And again, this is the type of data we need to finally land on how to best prioritize the vaccine eventually. And last slide, please. I just wanted to show it here because I think that's the other big piece in the media this week is this new COVID-19 response framework by the province. Hamilton is currently under yellow protect, but is moving into restrict, most likely, given our case counts over the last week or two. And for each sector, there's certain interventions based on where you are at within this framework. And this framework is publicly available if you're interested what it means for your gym. You can look it up there, what may change once you move into restrict or maybe into control later on. I think I stop here and we will have time for questions eventually. Thank you very much.
Thanks very much, Dominic. Yeah, I think we're going to go right to a Q&A as you are the only presentation today. I do see that some have come into the Q&A forum, which is great. That's if you have questions, please type them in the Q&A box, or of course you can always also raise your hand in the attendees or participants function and ask Dr. Mertz or any of our panelists a question, should you wish. So Dominic, I see here a question specifically about HEPA filters. I mean, as we think about the idea of airborne transmission, there's been some dialogue in the media about that. Are HEPA filters a line of defense against airborne transmission? Is it something that people should be considering in small and enclosed spaces as a way to mitigate that kind of transmission?
So first of all, I would like to avoid the term airborne in the setting of COVID-19. We can talk about aerosols. Airborne, that's really applicable to things like measles or TB that may actually travel through air currents out of rooms into other rooms and so on. We haven't seen that with COVID. The big discussion is around aerosols, in particular in specific settings. So typically meeting those magic 3 C's. So crowded places, close contacts, confined enclosed spaces with poor ventilation. That's where aerosols may play a significant role when you have those super spreader events in particular. HEPA filters can certainly take care of that. Any ventilation can take care of that. And why do we see events like that out in the community, say in a nightclub or in a bar or in a gym? It's because you don't have that basic ventilation. We have even in our old buildings, we have a better ventilation than in most settings out in the community. And at this point of time, in addition to not knowing how effective those cheap HEPA filters would be, we don't have any evidence that this would be any added value to the already existing ventilation that we have in hospital buildings. And even for, I mean, some people recommend it for schools and so on. I think it would be great to learn whether they are added value. I think at this point, we simply don't know. And that's why we are falling back to wearing masks.
So just out of respect for the person asking the question, they had typed in aerosol. I characterize it as airborne. So thanks for making that correction. But to the person who did ask the question, sorry, I butchered that part of it. And I think you've also answered the other part of their question, which was about what we're using at our sites. So thank you. Another question here about, as vaccines are rolled out, I guess it's too early to tell how it would be triage, but the question being, would it make sense to start with healthcare workers? I guess you could lump in there vulnerable populations. Would you have any observations about the rollout of a successful vaccine and how it should be done to maximize efficiency or effectiveness, perhaps?
Yeah, I think it goes back to what I already mentioned, right? I mean, healthcare providers, and in my mind, in particular, providers in long-term care facilities should probably be the first priority, because typically the virus is being brought in by staff into those settings. We also need to learn, and that's what I mentioned, first to know among those most vulnerable people, how effective is the vaccine there? If it's highly effective, it's less important for others to be vaccinated because we can protect them directly. If it doesn't work well, say in a long-term care facility resident, the best possible line of defense is to, as quickly as possible, vaccinate all staff there, so it will not be brought in to the same extent anymore. So we still need to learn more before we can define who that target population is. For those really interested in this, the NACI, if you search for that, our National Advisory Committee for Vaccinations has already put out a framework where they list potential priority populations that should get or should be considered for vaccination first, with a clear statement: once we know how it works in what population, and in particular how it works in the most vulnerable population, one can start to prioritize. This is the first, this is the second, this is the third population. It's a very important question, because obviously we will not have as much of the vaccine as we would like in the first few months, not even probably in the first year. So it's very important to make the right choices to protect as many people as possible, as quickly as possible. But still more to come. It's too early to say it should be approach A or B. We first need to learn more about the actual data, and there will be a national recommendation how this will be rolled out first.
And then as we think about the vaccine, another question here is like, how concerned should we be about mutations? And there was commentary recently about mink farming and certainly other areas where we're starting to see maybe some permutations around this particular virus. Would one vaccine address one problem, but then there's others that are being born at the same time?
Yeah, and again, I think that the mink farms is a great example of sharing medical information by lay media first, and the interpretation of experts is, yes, it might be a concern in terms of mutations. Others say, nah, not as important at this point of time. Again, mutations may and probably will happen at some point, and then the question is which strain will over the long term be the predominant strain. And obviously, and that happened with other vaccines like pneumococcal vaccines, if there are multiple strains of this virus out there and we can target the currently clearly dominant strain and it works for all of those, it opens up a niche for some mutations. So we need to see how this will eventually play out. But it's not that people are super scared now because of what happened in that mink population. And I think that the books aren't closed yet on whether this would have an impact on the efficacy of the vaccine or not. So too early to say. I think with all the surveillance that's happening worldwide, we have a very strong network now to identify clusters of mutated virus, and we have to take it step by step.
There was I found it interesting, the information you were unpacking around serology studies. Has any of that been done locally in Hamilton to assess prevalence locally?
I'm not aware of anything that had been done outside from a population perspective, outside of what the province is doing, where certainly Hamilton data flows into. There's some studies that do serology testing in their population for specific question, but that's not data that would necessarily give us a better feel of how prevalent antibodies are in our population. Optimally, you would have a so-called population-based sample, so a representative sample of people giving their blood to get tested. And I'm not aware of any studies that would have done that specifically for Hamilton.
So a question that's come up, and I know I've had this discussion with my barber, my neighbor, my mother. If a vaccine is rushed, is it safe? Like what should we be considering when we think about taking a vaccine that with the best of intentions is being brought to market, perhaps in a less than traditional scientific pathway?
So in my opinion, we are doing the right thing in, I would say, the Western civilization by saying we first want to have the data that we would expect to see for any vaccine we throw out there first, before we make a decision whether we can approve the vaccine or not, whether it's effective enough and whether it's safe enough. And safety is going to be very important. And just keeping in mind here, we are talking about a disease that more than 99% of people are going to survive. So once you start vaccinating millions of people and you have very severe outcomes, hopefully not, but I'm just putting it out there, we want to be as sure as possible that we do not have to expect major adverse effects from the vaccine. The typical phase 3 studies have around 30,000 people vaccinated. So that's a good number of people. Is it likely that we will find one or the other side effect after that once we roll the vaccine out? It's very likely. It doesn't seem likely that it's something that will be very common. Whether it will be major or not, we will see. But we've seen it with the first iteration of the rotavirus vaccine, for example, that was pulled back once it was rolled out. So vaccine safety is something that happens during the clinical studies, but then just continues because given that you typically vaccinate millions of people, you need to make sure that that balance of benefit and risk is still in favor of the benefit. What I can say, based on the data we've seen so far, we don't have any concerns in terms of safety as far as we know. Many trials have had to be stopped for a certain time period because there was an adverse event that needed to be worked up. But it looks like it was never felt to be related to the vaccine, so the trials continued. So that's all good news, and hopefully that will hold true at the end of the trials. But keep in mind, the safety assessment will continue over the months and years to come.
Yeah, I think it'll be a very important moment in time, and as we've seen, the media and social media dialogue around these issues can drive it in different and unhelpful directions. So a topic that we'll be keeping our eye on for future forums for sure. Thanks for that answer. I got a couple questions about masking here. One related again to aerosol transmission. Should we be using the N95 mask? I know this is a topic of great discussion in Wave 1, the appropriate use of the N95 mask and in which settings. So the question here is specifically pertaining to a small clinic room with patients and families. I guess the notion being that proximity, should we have an N95 mask in use to prevent aerosol transmission?
So yeah, I mean to start with, and I think it came up again with the latest PHAC statement, which is now aligned with the WHO statement and the CDC statement. And just to be clear, there hasn't been any new data recently. It's just acknowledging that aerosols may play a significant role in those situations that are outlined previously that meet those 3 C's, basically: exposed over a prolonged period of time, insufficient poor ventilation, crowded places, etc., etc. Not something we would necessarily see or don't want to see in a hospital setting. So that's the first piece. The second piece is the recommendation to have 3-layered masks from PHAC. Again, that's not new. All the data, or most of the data we actually have that cloth mask may be of any benefit, was based on 3-layer cloth mask. But to make it easier for all of us, the recommendation was, well, just put something in front of your mouth and nose and you will reduce something. Now they put out, well, 3-layer cloth masks is superior. Yeah, we knew that. We knew that since back in March or previous to that as well. The more layers you have, the less likely it is for any droplet and smaller droplet and aerosols to go through. Just to remind people, a medical mask is providing a much better protection than any cloth mask would. So even compared to those 3-layer cloth masks that are recommended by PHAC now, given consideration of super spreader events out in the community through aerosols, we are still better protected with our medical masks. None of those studies would have suggested we need anything other than medical masks. So it will not result in a change of recommendations there. Not at this point of time. PHAC and WHO haven't changed any recommendations in terms of management in the healthcare sector. I will put it that way. We have a Q&A actually on the hub around this entire topic, and I would like to motivate people to have a look there. And please, I mean, we get lots of those questions by email. Please feel free to reach out. We are happy to have a conversation with you about this topic. And just to mention it here, we are doing a study as well with Mark Loeb as the primary investigator, comparing N95 versus medical masks to hopefully provide a definite answer to the question whether medical masks are as effective as N95 to prevent transmission of COVID-19. And everyone who's working in a setting where we see more of those patients, so ED and COVID unit, would be eligible for this study.
Another question here on the topic, you know, and others may want to weigh in, those that have been involved in a similar conversation, but as people do reach out, I mean, clearly in the medical setting, there's probably fewer of these people that work at HHS, but likely some that have come into our spaces where someone is just adamant or resistant to wearing a mask. What's the best way to approach that conversation? Either discussing relative risk or how we manage population health or public health. Any suggestions about how to engage someone on that topic?
Doesn't look like anyone.
Dominic, I think this one's falling to you first.
It doesn't look like anyone else wants to weigh in here. In my mind, there are two aspects of that, right? So first of all, the main concern that many healthcare workers have is that the main risk that we get exposed to as healthcare providers are our patients. I think what we've learned across the province over time, it's more our colleagues, unfortunately. So just keep that in mind when you have those conversations, and try to be as empathetic as possible with that individual. Some people may have a valid reason not to want to wear a mask. Others don't have a valid reason and just don't like it, whatever. I think we have an obligation to provide care when it's needed. If it's something elective that's not super urgent, there's certainly the option to say, you know what, it's not the right setting for you. So we certainly have that option, but it really needs to take into consideration the risk that you put on the patient. The level of protection that we have with our masks, so our medical mask, not the cloth mask out in the community, with our medical mask plus eye protection, should protect us even if that person happens to have COVID-19. So again, with your PPE, you are protected, and in doubt, you can consider the patient infected if they don't want to wear a mask, and you can still take care of the patient safely. And I think that's the key piece there. There's certainly people where typically it's multiple layers and the mask is only one issue, where there might be better options than providing the care at that point of time. But I think I will take that into consideration as well, trying to understand why they are not willing or able to wear a mask. And you may find the solution by just saying, well, maybe banana, whatever, to put in front of your mouth that you have at least something, are certainly options as well.
Question here, Dominic, about the process for the clinical trials for vaccines. Do you know, are they testing all age groups, children, older adults, as well as midlife adults?
So I can address the children question. There's only the Oxford vaccine, which I think recruits down to age 12. That's my recollection there. None of the other vaccines are being tested in that patient population. And I think it makes an awful lot of sense as well, because in terms of where do you get the biggest bang for your buck, it's obviously not in the children who typically have very mild disease. You want to protect first and foremost those who are at risk for severe infection and those that may infect those at highest risk. And that's again, healthcare providers, in particular in a long-term care setting. So I think it makes sense that so far, most manufacturers are sort of staying away from kids with in the trials. For the elderly population, I can only say I sincerely hope that they did recruit a significant number or representative sample in that population, because that's really the piece of data that we are most interested in, beyond just on average it works in 90% of people. I would like to know, well, in those that have the highest risk for complications, how well does it work in them? I haven't seen any data how the patient population looks like, so how many of those elderly people with multiple comorbidities have been enrolled, but that's the kind of data that we expect in any scientific publication of the data, but doesn't make it into any lay media reports as we've seen with Pfizer.
A lot more to learn. I think there's a question here. If I get it right, I think I understand what the question is does the severity of the symptoms of the virus at all, I'll ask it as it's written. Does the mortality rate or even the severity of symptoms of the virus affect the spread or lifespan of the virus in our population? So are we better off as a population if we're individually less affected by it? So I think the question is if we all got a mild case, would we be better off than letting the current spikes and severity persist?
The problem is, and I think that's another piece that we unfortunately failed in, is protecting those at highest risk, right? We weren't successful in Canada. The European countries haven't been successful either, unfortunately, in just making sure, or not to the extent that we would wish for, to protect those most vulnerable. I think obviously the easiest solution to this entire very contentious topic in terms of, well, how much should we allow the virus to spread? At what point should we do a lockdown? What are the pros and cons of either approach? It's a very contentious topic, as everyone knows. Obviously, the easy solution out of that is the vaccine, and fingers crossed that we'll get one sooner rather than later. I would agree that the population that typically has mild disease in itself wouldn't require any major interventions. The issue becomes that we haven't been able to keep it in that population, that eventually it spills over into long-term care facility, into the elderly population. So we have done a poor job in preventing that from happening. And I don't think enough work had been gone into that, to be honest, and there might be ways to do it better. But what we see now in wave 2, unfortunately, is very similar to what we've seen in wave 1. In wave 1, we weren't aware of those mild diseases to a large extent because we wouldn't have tested them. Now we test them, we know about them, but what we see in terms of hospital admissions and death is, again, the elderly population that we are unable to protect, in particular in long-term care.
Interesting. You had mentioned in your presentation, Dominic, that around September, we saw an escalation in rates ahead of schools opening. So maybe that tells us that, in fact, the opening of schools didn't really increase the spread of the virus. I've also heard, again, in lay media that arguments for or against schools as a place where the virus can spread. Can you maybe underscore for us what the science is saying right now about the impact in schools and what we should be thinking about?
You can ask two people looking at the same science and coming up with different interpretations, because the science is not black or white. And that's true for many aspects of what we see and do with COVID, unfortunately, because we don't have randomized trials that give us black or white answers. We don't have the best possible study out there to rule out that schools are major drivers, because we don't necessarily test all the kids exposed within a class bubble, say, if we had one student sick, there's typically a recommendation, well, maybe you get your child tested during those 14 days of self-isolation. Many wouldn't. So you can either argue, well, they didn't get sick, so there wasn't any transmission, or you can argue, well, there might have been transmission. We only don't know about it because we haven't tested reliably in those contacts. So you can go either way in that conversation. I think from an ecological standpoint, and that's why I highlighted that, it sort of coincides with mid of September, we see an increase, and that's when the schools opened. But fact is, the increase started earlier than that, and you would only expect to see an effect of school reopening typically 2-3 weeks later. And it doesn't look like the trend that you've seen changed anything significantly after reopening school. With this being said, of course, you have the occasional transmission in school. That was to be expected. First and foremost, it's a mirror of what's happening in your community. The more cases you have in the community, by chance alone, the more cases you will see eventually in kids that attend school. Doesn't mean that the transmission occurred in school, and doesn't really give you an answer how safe the school environment is. If you ask me what I'm doing, my kids are in public school, and I feel comfortable with that.
Well, great. Thank you, Dominic. You've exhibited great stamina in taking on these questions today. Always enlightening, and really appreciate your presentation on many topics related to the pandemic today. Rob, maybe if I could bring you back, conscious of time, we could do a call out quickly for some celebrations and wrap. And just to say, anyone that had questions lingering in the inbox, we'll do our very best to get you an answer directly or via the hub. Thanks a lot.
Hey, thanks, Aaron, and thanks, Dominic. I think actually, Eric, we're so close to the end that unless we can get some very quick shout outs, I'm going to suggest we make sure that we save some time for celebrations at our next town hall. But I do see Kelly Campbell has given a shout out to the Satellite Health facility staff and leadership. So thanks, Kelly, and thanks to all of those folks at the Satellite Health facility, which is such an important addition to our capacity and our ability to continue performing procedures and surgeries and so on. But I'm going to suggest that we close it down now with 2 minutes to 12:30, and thank everybody for coming. Thank Dr. Mertz for sharing his time. And we'll make sure that we share a bit of extra time next time for celebrations. So thanks all, and hope you all have a great day.